It's actually for RNs to learn EKG. And in this tutorial, it talks about things like the conduction system, how to read an EKG, how the wave components, and then it's got all the dysrhythmias down here, and it shows you a picture and what you're looking for, okay? And all these things. Now, you do not have to know any of these blocks. You're out of that program. But there's these two you need to know, and you need a couple of down in here. But I gave you the list on the first slide, so it makes it easier for you. And then if you really get adventurous, you got to take the exam at the end. I think a 2-year-old can pass the exam, but that's okay. So this is what I'll be sending. I will be posting for you, because I'll tell you right now, EKG is nothing but pure memorization, and I cannot memorize for you. What I'm going to do when we get to class is I'm going to help you find ways to recognize the rhythms. But memorizing them, I can't do it. And they're all the same. If EKG rules will be EKG rules to the day you die, let alone me. So I will be putting this up in MedSearch 1 and also in the other course.
The community course? The community course?
Community course, which is getting to look differently. The other one that's due, and this is due to be done the second day of class also, this is mandatory, is a tutorial that I put together quite a while back, but it's still very actively involved. And it's an introduction to cardiac diseases, because in MedSearch 2, you're going to get all your cardiac stuff.
Welcome to it.
Oh, shut up. That's me. But this one is very interactive, okay? You go off-site, there's also a lot of open links here. And what you do is you go on these links, if it wants to open, but it doesn't appear to want to open right now because it just decided it didn't like me. Let's see if I can get it. Oh, yeah, here we go. So, like here's a labeling exercise, and if you take the little thing and you put it on the right spot, it stays, but if you put it on the wrong spot, it goes back. And there's all these different interactive things in this tutorial for you to be doing. And that is required by the second day, because in those first 2 weeks, you're getting all cardiac stuff. I mean, all of it. So my suggestion is I'm giving you the opportunity to be looking at it while you're out. Now let me put up my lectures for today. And actually, since I'm doing EKG stuff right off the bat, I'm going ahead and posting the actual lecture notes. So you'll have everything for that first week, which is only 3 days. It's a short first week. Be happy about that. So today we're going to talk about the concept of infection, and our exemplars are going to be pneumonia and TB. Okay? So let's do a little background, and I got to figure it out. She always gets the wrong one. I can't see anymore. Oh, I like this. Hey, did you hear the joke about the germ? Sorry, I don't want to spread it. I will keep your afternoon lively. Well, I will attempt to take it that way. Okay, so let's talk about infection. It's organisms that invade our body tissues, okay? They can be foreign substances, infectious agents, abnormal cells, such as in cancer, and drug-resistant organisms, because we're getting more and more drug-resistant organisms out there. Now, what can it be? In fact, first of all, the most common is bacteria. You got bacteria all over your hand. right? We got bacteria all over everything in the world. Okay, and it can be transported by air, water, food, soil, you name it. Tissues. That's one of the reasons why we use PPE in the hospital, personal protective equipment, especially when we're dealing with anything that's body fluids or blood. Okay, viruses, the next most common one. These guys have to be in the cell to actually propagate. And these things are our rhinovirus, our flu, hepatitis, herpes, HIV, all of those little fun things. And then we got fungi, okay, or yeast and molds. Now, what you gotta understand about yeast and molds, some of them are natural to our body, especially to our GI tract. Okay, so it's normal flora, and we don't need to do anything about it. But there are some fungi and yeast. One of the biggest things is yeast, especially in women in the hospital. And that's why we use nystatin powder all the time. Okay, then we got parasites, the wonderful world of parasites. The bugs within. All I remember is that show where things were swirling underneath somebody's skin. I'm going, oh, isn't that great? These have to live on other organisms, and we got protozoa, which create malaria, helminths, which are worms, which invade, and arthropods, mice and fleas and ticks and all those things that love our dogs and cats. Now we have local infections, they're limited to a specific area, like a sore on your hand. We got systemic infections, where the organisms can go in our body and go other places in our body and cause more infection. And then we got bacteremia. This is one of the biggest ones. You will get sepsis and MS too, I think. And where the blood gets invaded by bacteria. And it travels throughout the whole body and causes sepsis or septicemia. Now, we have acute infections, okay? And they just happen very suddenly, but they disappear just as fast as they come. Okay? And then we have the chronic infections. They just have to develop over a long, long time. And I hate to say it, some of these infections people can be plagued with for their whole life. So chronic infections are not a good deal. So this brings us now to respiratory disorders. Never mind. Okay. So, true or false? Type 2 epithelial cells in the lungs are responsible for storing and secreting surfactant. True or false? I'm not hearing a whole lot. How many say true? How many say false? How many are totally clueless? And how many I just don't want to do it, don't want to be seen? The answer is true. The answer is true. And you'll see as we get going here. Now, of course, our anatomy, a little bit of anatomy, which you all are so brilliant with. Of course, our lungs are in our chest. We got two major organ systems in our chest, and that's our heart and our lungs, okay? And that's because they work together. Okay, the lungs, though, are much bigger. They surround the heart, so they kind of protect the heart from damage. And then, of course, we've got our rib cage, which protects our lungs. The only problem is you can poke through things and into the lungs between each rib. Okay? So we did a simple anatomy. And, of course, when it comes to our respiratory tract, it starts with our nose, our nasopharynx, and our oropharynx. And then it crawls all the way down, goes down our trachea, into our bronchioles, and then in the rest of it, all through our lungs, so that we can exchange gas. Now, to protect the lungs and to get them to inflate, we have a pleural space. Okay, and it has an interior and an exterior membrane. And in between the two membranes, there is pleural fluid. And usually it's only a few cc's, normally. And it acts as a lubricant for these two membranes to slide back and forth as we inhale and exhale. The problem with this little space, though, this little space can hold up to 2 liters of fluid under the right circumstances. And when fluid accumulates in that pleural space, of course, everything works by gravity. So what's going to happen is it's going to go down to the bottom of the pleural space, and all that fluid is going to accumulate and start pressing on the lung tissue itself until the alveoli collapse and part of the lung collapses. Okay? So we don't like all that fluid in there. We just want those few cc's of fluid to lubricate, not a bunch of things. And that's one of the reasons we have pleural effusions, because fluid is accumulating in that space. The other thing that's important about the pleural space is it maintains a negative pressure in there. Normal pressure within the lung is -4 to -10 centimeters of water. And that's what keeps our lungs inflated, because when we're inhaling atmospheric pressure. If the lungs were able to get, if that pleural space wasn't negative to keep the lungs up, we would, with every breath, our lungs would collapse, because the atmospheric pressure would just collapse them. So the pleural space stays negative, and that is what keeps our lungs up. All right? Now, again, we can rupture our pleural space by something going through us, and then we're going to drop the lung automatically, because it's now exposed to the atmospheric pressure. But that little piece of information is going to be important when you get to chest tubes, because chest tubes all work off this negative centimeters of water. All right? So something to keep a thought about. Now, problems that we can get in the pleural space, number one is a pneumothorax, and that's where there's a hole between the lung and atmospheric pressure, and that's why it collapses. Okay? You can have a hemothorax, that is where there's accumulation of blood in the pleural space. And you can have pleural effusions, which is a common problem post-operatively. And that's just fluid collecting in that pleural space. And then we can have an empyema, and that is a purulent infection that is caused in there, and it causes purulent drainage. All right? So there's several things that can go wrong with our little pleural space, which will ultimately affect our breathing. Now, of course, as air passes, it's going to go through the trachea, where I got it to the carina, and at the carina, that's where the left and right branches of bronchioles go off, your bronchus. And of course, then we have a secondary and a tertiary, and then we get to our fine little bronchioles and terminal bronchioles, and then our little alveoli, which look like little grapes, grape clusters. Now, one thing I do want you to understand here, gas exchange does not only occur in the alveoli, but it occurs in the terminal bronchioles. It starts in the terminal bronchioles. It's not all just the alveoli. And of course, our little alveoli, these little things are totally encrusted with capillaries. And there's over 3 million of them in each one of our lungs. That's an awful lot of little alveoli down there. All right? And like I said, they're surrounded by the capillaries, and blood cells go by one at a time to do the gas exchange. Now, here's one thing I want you to understand, because people mix these two terms up all the time. Everybody says respiration and ventilation is the same thing, and it is not. Ventilation is just the movement of air in and out of our lungs. That's all it is. Respiration is the actual gas exchange that is occurring between the gas, the O2 and the CO2. So respiration and ventilation are two completely different things. Now, in these little alveoli, we've got type 1 alveolar epithelial cells and type 2 alveolar epithelial cells. Type 1 cells maintain the blood-gas barrier, and it takes over 90% of the surface of the alveoli. The problem with the type 1s, though, they're very, very, very susceptible to injury. All right? On the other hand, our type 2 cells produce, store, and secrete X, pulmonary surfactant. And again, it's a lipoprotein, and what it does is it lowers the surface tension so we breathe easier. Okay? So it decreases the amount of pressure we need to be able to take a good deep breath, and prevents the collapse. That is why a long time ago, when people had premature babies, a lot of them died because they didn't have any surfactant. Their body wasn't making it. Now we've got an artificial surfactant that we can use on these babies, and they're learning that they live. So surfactant is an important thing. But the other good part about these type 2 cells is if type 1 cells get injured, type 2 cells can morph themselves into type 1 cells. So they got 2 little big jobs that they got to do. Now, of course, gas exchange occurs at right at the alveolar level. Respiratory gas exchange, okay, because it's respiration. And it's always high concentration to low concentration of the gases. Okay, that's how they move. It moves in and out of the blood system. Okay, high, low. The other thing good about our lungs is we have all these protective mechanisms. First of all, we got air filtration, okay? Starts with the nares in our nose. It starts catching large particles so it doesn't go down into our lungs, okay? Then we've got our cough reflex. Our cough reflex that helps us get stuff out of us when we got goop down there, causing problems with gas exchange. We've also got mucus secretions, which also, if by chance a particle gets past our nares, it'll stick, because the mucus secretions are real sticky, and it'll stick to that so that it doesn't go down any further. And then we got our mucociliary escalator. This is our little escalator up here. And the escalator, as particles get stuck on the mucus, the little escalator starts moving the particles and the mucus up till it hits our gag reflex and causes us to cough and cough it out. Okay? So it's really kind of cool. We got a whole protective system going on down there. And then we got our alveolar macrophages. These are our scrubbing bubbles of our lungs. Literally scrubbing bubbles. Because they secrete peroxide. And they help clean the lungs and keep them clean. Way long time ago, when we had patients on ventilators that we had a lot of secretions, we would actually mix sterile water and peroxide together and squirt it down and then suction them to help loosen up stuff and to kind of like try and make a more sterile environment for the lungs. So we got that. And then, of course, in many cases, like when we're in a lot of smoke or in a fire or something like that, or too much smog, we got bronchoconstriction to help protect our lungs. And then the big one of all is epiglottis closure. Our epiglottis closes and opens. It only opens when we're eating. But when we're not eating, it stays closed and the oxygen goes directly into the trachea. And if you think about it, trachea is anterior, esophagus is posterior, and they kind of come down together. So we've got all sorts of little protective mechanisms. Now they have proven that smokers that have smoked for like 20 or 30 years, i.e., we have deficits in our microphages. Our cilia become impaired, and we have a lot of constriction. So again, it's going to impede gas exchange, but I'm not blue yet. Keep it that way. I'm not blue yet. Now, when we breathe, it's fairly easy. When we breathe, our chest cavity expands, our diaphragm pulls down to suck in the air. That all takes energy. That all takes energy. But when we go to exhale, it's like a natural recoil. It just automatically snaps back into place. We don't have to work to exhale. We only have to work to inhale. And when we do EKG, this comes into play very much so. All right? So, and it's important. What makes us breathe is actually our arterial CO2 levels. That's the stimulant. That's one of the reasons we do blood gases. Because elevated CO2 in our blood gas is going to make us breathe faster in an attempt to blow off the CO2. And you guys are all brilliant on ABGs now, aren't you? Yeah. But no, this arterial CO2 level is really important for COPDers. And that is what we call their hypoxic drive. That's what keeps them breathing, by having an elevated CO2 level. So it's important. Now, when it comes to pulmonary circulation, look at it, so take it this way, it's a very closed system. Okay? Blood goes from heart all the way through, gets deoxygenated and feeds and nourishes the organs, etc., comes back deoxygenated, goes up to the lungs, gets more oxygen, comes back down. Now, it's a closed system, but we invade it continually. Every time we put something in, put an IV in, we're invading the system. If we put a central line in, we're invading the system. And so the thing is, we have to have our heart and our lungs working well together for us to get good oxygenation to our body and our organs. If there's something wrong with our lungs, it will eventually affect our heart. If there's something wrong with our heart, it will eventually affect our lungs. And that's going to be important when we start learning things like congestive heart failure. So that's another thought process. Remember, the two have to work in synchrony for our body to work, perfuse. And of course, our respiratory center is totally found in the lower brainstem. Now, think about it. That's way down here. All right? People who've had a stroke, it can affect the lower brainstem and they won't breathe. Traumatic brain injuries, where we have all sorts of swelling going in this closed capsule up here, can press down on that lower brainstem and stop us from breathing. Cervical spine fractures can affect it by bone penetrating it, and we can lose our ability to breathe. So it's just kind of just a good thing to know that it's way down here. A breath of fresh air, 50 cents. Da-bing-da-boom. Never mind. You guys must be tired today. I don't know what's wrong with y'all. Okay. Now, pulmonary assessment. We talk about inspection, palpation, percussion, and auscultation. Now, for some reason, nurses don't very often do palpitation and percussion, which I don't know why. Because it gives us a lot of information. We should be actually doing all four of these things when we are doing a pulmonary assessment. Okay? So the first thing we want to know about when a person comes in with a pulmonary problem is, okay, what's going on? What's your present illness? What seems to be the problem? How long have you been having it? How bad is it? Is it affecting your ability to move around and do ADLs and everything else because you can't catch your breath? Is it located in one specific spot? Or is it both lungs? Okay, what makes it better? What makes it worse? And what causes it, especially people with asthma, what triggers it? Now, the big thing here is because the heart and lungs are in there together, when anybody comes in with certain issues, we have to rule out whether it's pulmonary or cardiac. Do you know how we do that? Somebody comes in with chest pain. We tell them to stop breathing. Just hold or take a deep breath and hold it. If the pain goes away, it's pulmonary in nature, but if the pain stays, it's cardiac. And that's how we start to differentiate if it's cardiac or pulmonary, because they work together. And it gives us a lot of information by just having them hold their breath. Okay? We also need to know their past medical and surgical history. And that is extremely important, especially if they have COPD, or they have bronchitis, or they have asthma. Or what if they've had lung surgery and had a lobectomy done, part of their lung was removed? Or what if they had a pneumonectomy and one whole lung was removed? That's going to be important to know. Of course, with everything, we need to know past social history. what medications they're on, and what their allergies are, what their smoking history is. That's always a big question. Other drugs, and we're talking like over-the-counter drugs. We're talking like vitamin drugs. We're talking illicit drugs. Nowadays, right on the nursing admission assessment, right there, it asks you if you do drugs. And I love it when patients look at you and say, absolutely not. And then they do a urine test on them, and they find opiates in there, and they find cannabis in there, and they find, ouch, give me a break. No, I don't do anything. I don't believe patients a lot, especially when, how much alcohol you drink? 2 beers a day? Probably a case and about 2 quarts. I don't know. And that's why you go to the DTs. Give me a break. Okay? Next thing we want to do is look at him. Just watch him. Does this guy look comfortable? Nah. Just watch him breathe. All we got to do is sit there and watch him breathe. Tells us a lot. Do they seem comfortable when they're breathing? Okay? He does not. Are we using accessory muscles? Yeah. What's his color? Is he blue? Is he pink? What is going on? What position? You're right. He's sitting up, leaning forward, hands on knees, pursed lip breathing. He's probably having a hard time. Okay? Ability to speak. We've had patients that come in and we ask them to give them a simple sentence and they come back at you. They go, the dog went over because I can't catch the ball. So can I even talk? Are they making noises? When you have patients in pulmonary edema, you don't even have to go in the room. You can stand at the doorway and hear them. Okay? And do they have any kind of chest deformity that could possibly prevent them from fully inflating their lungs? Now, whoop, 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 okay. Now, assessment. Vital signs, every time we do vital signs, what do? We do a pulse ox. We want to know what their SAO2 is. Right? We always do a pulse oximetry. And get saturation on it. We got to look at their chest wall configuration. Do we have symmetrical or asymmetrical breathing? Okay? We got to look at their mucous membranes. Are they pink? I hope so. Nail beds tell us a lot. Do we have a brisk capillary refill or not? Mental status. Number 1, the first sign of hypoxia is usually an onset of confusion. And that's because not enough O's are getting to the brain. Okay? So confusion, agitation. I mean, if you're taking care of your patient one minute, and then an hour later you go back and they think they're in World War II. Something's not right here. Okay, and then we need to know our breathing patterns. We've got hyperpnea, which is also another term for tachypnea, which is too fast. We got bradypnea, which is too slow. We got dyspnea, which is shortness of breath, or short, SOB. We got orthopnea, and that's where it's positional. Those are the patients that have to sleep with like 3 pillows. The things you don't want to see is chine stoves. And that's where you got rapid breathing, slow breathing to apnea, and then back to rapid. It kind of goes like this. It's usually a sign that they're kind of going to visit upstairs. That we don't like seeing them. And then we really definitely don't like apnea. Okay? That is definitely a cause for major concern. All right? Okay, so that gives you something. But remember I said you want to look at nail beds. Look at this lady's nail beds. They're blue. This is a pure sign of central hypoxia. Pure sign of central hypoxia. Then, of course, people with chronic respiratory issues, you start seeing clubbing of the fingers. That is another significant sign of chronic hypoxia. Now, when it comes to the chest itself, we have things like pectus excavatum, which is funnel chest, and it's usually found in children. It's usually congenital. And it's where they have a big indent up here just above the xiphoid. For some reason, the sternum curves in instead of going straight. Then we've got a thing called barrel chest. And this is where there is an increase in the anterior-posterior diameter. And it is usually caused, it is a sign of chronic hypoxia, but it's usually caused to continual hyperinflation. So it expands our chest. And then we've got this wonderful thing called kyphosis, which is a progressive spinal disorder. It's also known as humpback. Okay? And it's usually in the thoracic area. Oh, like this little baby. Like, whoop, 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 like this little baby. And so what happens is because of the humpback, they cannot have a complete chest expansion with a breath. And it is very progressive. And it's usually thoracic area. All right, liven up, kids. I can't breathe, honey. Are you choking, Morris? No, I'm serious, damn it. Thank you. You're making me feel very bad today. Now, like I said, one of the things nurses don't seem to do, which we should be doing if we have the ability, is palpation. We want to look for normal excursion. And basically all you do is take your hands, put your thumbs down either side of the spine, and your hands press out. And when the person inhales, it's supposed to come apart by 1 inch. And when they exhale, it comes back. But it should only expand by 1 inch with a good inhale. If it's more, you probably are dealing with somebody with a barrel chest. But we should be doing this stuff. And not only that, while you have your hands on them, we can look for tactile fermatus by just getting them to say 99, 99, or blue moon, blue moon. And you can feel, if there's junk in there, you will feel it rattle against your hands. So I don't know why we don't do this stuff. I think it's very important. It tells us a lot of information. And then, of course, we should always be looking at tracheal positioning. Because when we get to reasons why we have to put chest tubes in, one of them is a pneumothorax. And when a person has a pneumothorax, the trachea is totally going to deviate. So those are some things we need to think about. And then the other crazy thing we don't do, which actually is a skill, but it's an easily learned skill, is percussion. And basically what we do, we go from the edge of the scapula and draw a line, and then the spinal column to the top of the diaphragm. And all we do is go down and we take one hand, put them on it, and we tap our nail. Okay? We tap our nail. That's all we do. We just sit it there and go tap, tap, tap. And number one, if it's a flat, resonant sound, okay, if it resonates, that's normal. But if it's a dull thud, number one, that can tell us that we have fluid or consolidation in there. Or else we're sitting too high up, we're too low down, and we're over an organ, and usually it's the kidney. So it tells us if there's junk in there and where it is by just doing percussion down their back. And so we can actually tell whether it's consolidated, like goop, mucus plugs, etc., or fluid. Okay? And both of these are the biggest complication postoperatively in anybody that's on prolonged bed rest. Okay? So that's one of the reasons we want them to get up ambulating early. We want them to be doing coughing and deep breathing. We want to be having them using stent spirometers so that we can avoid this. And the thing is, if you have this much consolidation or fluid, you're not going to hear breath sounds in that area. you will have absent breath sounds because you can't hear when there's no gas exchange occurring. Okay, and then of course what we always do is auscultation. Now, you need, and here's a little hint for you guys when you get something. You can do this at home. You can be sitting in your pajamas, drinking your coffee, and I don't care. You can start naked for all I care. The biggest learning curve you guys are going to have is going to be breath sounds and heart sounds. All right? Biggest learning curve. Super simple. Just sit in front of your computer with your coffee and your pajamas. Put your stethoscope in your ears. Go to google.com. Gee, it's so hard. I love Google. Google.com. Put your stethoscope in your ears and put it on. You're going to be holding it right to your mic. Now do me a favor. Turn down the volume so you don't blow your own ears out. But all you do is punch in heart sounds or punch in lung sounds. Most of the time you find them both together. And what you want to do is find a website that's audio. And what you do is you sit there with your stethoscope and listen to normal breath sounds till you got them down. Then you go to an abnormal breath sound. You listen to it. You start going back and forth between normal and the abnormal. Back and forth, until you find the distinction between the two. Okay? Then you go find another abnormal one. You listen to it, and you go between normal and the second abnormal. Back and forth. Till you got it. Then you go between the two abnormals until you got the differences between those two. You do the same thing with heart sounds. And that is how you are going to learn your heart sounds and your breath sounds. It's just a little trick, but it works. And like I said, you just do it a couple times a day, during the day, one day, and you're all set. Because you need to be able to distinguish what the heck you're hearing in that chest. So, of course, you got abnormal breath sounds that are either absent because maybe the lung is collapsed, or diminished because there's a lot of goop in there. You can have displaced breath sounds. I think the best one for displacing sounds is when we had a trauma patient who ruptured his diaphragm in the accident, and his intestines came up into his chest. So instead of hearing breath sounds, you were hearing bowel sounds. Then you got to know your adventitious sounds. Okay, crackles, which I also know as rolls. Okay, those are usually at the end of inspiration. They're high pitched. They're real short. Okay, that's crackles. Now you can have coarse crackles, which is when they start sounding like a washing machine. Then you got bronchi. Bronchi are deep snoring type sounds. Okay, a rattling. The cool part about bronchi is with a good cough, they'll clear, where crackles will not clear with cough.
Crackles where at the end of expiration?
Take it throughout all day. Inspiration and expiration. Of course, and then wheezes are your high-pitched squeaky stuff, if you've ever heard anybody wheeze. And then you can hear a thing called pleural friction rub, and this is where it's kind of a creaky, grating kind of thing. I always joked about it because I used to always call it the duck. And when my girlfriend and I would admit a fresh open heart, I'd be doing the assessment and she'd be writing as I was calling out what was going on. This is when I worked for Dr. Carmichael down in Ocala. And I would go S1, S2, quacker. And he said to me, "What's a quacker?" I said, "A pleural rub." He says, "Why a quacker?" I said, "Sounds like a duck." I said, "Here, listen here for yourself." And he did it. With each breath. So I had S1, S2 quacker. What can I tell you? Hit the duck. Okay, let's see how brilliant you are. Gas exchange starts in the alveoli, the terminal bronchioles, the upper bronchioles after the first bifurcation after the prime. Terminal bronchioles, thank you. Okay, let's get through diagnostic testing in a hurry because then you got going great. Okay, first big diagnostic test is chest x-rays. Number one, they don't want you to have any metal. So if you have necklaces on, stuff like that, off, it's got to come. All right? But what we can see on a chest x-ray is we can see if a person has an endotracheal tube. You can see if they have an NG and where it is, if they have a Dothoff tube, if they have chest tubes. Now, but you can also, here is the aortic arch right here. Here's your left ventricle. Okay, so you can see the whole heart. Now, you see how dark this all is? That means it's air. If it's consolidation in there, it's going to be white because we can't take an x-ray through consolidation. So we want it. This is the most perfect, beautiful x-ray I've seen in a long time. Okay, there's nothing wrong with this dude. Now in this one, number one, this guy has to have spina bifida because look at how that spine is going. But number two on this, I can see very clearly, here's an NG tube coming right down and into the stomach. Okay, and these are electrode wires. But the other thing that's significant is look at how short his lungs are in comparison to that one. And look at how, we call this a hemidiaphragm. Look at how high up it is. It tells us a lot. And plus, it is not all that black. So there's stuff going on in here. He also has a very enlarged heart. But here comes the fun. I love having fun with you guys. This is a sword swallower. Okay. Here's a person with severe cardiomyopathy. Here's a person with pacemaker. And the pacemaker wires go right down to where the heart is. You just can't see it because the thing was cut off. But that's a pacemaker. I told you I spend lots of time on Google. Me and Google have too much fun. Okay, another diagnostic test is a bronchoscopy. All right, now to do a bronchoscopy, number one, you do have to have an informed consent. Okay? And what we use it for is usually to either get a biopsy to diagnose something, or we use it a lot for mucus plug removal. Okay? Now, to do this, we have to anesthetize the oropharynx so that we knock out their gag reflex. So we can put this tube down here. So usually they'll use something like, it's called lidocaine spray, or we'll give them lidocaine gel, anything to numb the gag reflex. Because we're going to go down there with a big tube that's at least as round as my index finger. All right? And we're going to go down there to take a look around. So we've got to numb the gag reflex, otherwise they have a possibility of aspiration. And for that reason, they're NPO for 6 to 12 hours prior to the procedure. All right? Now, the big key about this, after they go down and do the procedure, this person cannot eat or drink anything until their gag reflex returns. Otherwise, they will aspirate. So, because we're knocking out the gag, they cannot eat or drink anything when they come back for a while. Also, we've got to make sure that they're not having respiratory issues such as laryngeal swelling, because sometimes people have it irritates them and they start to swell, and then we're going to lose their airway. So we got to monitor for that. We got to monitor for any bleeding. If all of a sudden they're having hemoptysis, something happened during the bronch. And we got to assess for pneumothorax, because there's nothing to say and I've seen doctors do it. Nothing to say that the bronchoscope didn't poke through the lung. We don't know. Other diagnostics we can do is CAT scans. It's going to look for bleeding areas, tumors, if there's a chest X-ray. Actually, a CT will show fractured ribs beautifully, especially with anybody who has a trauma. And then the other big one we do is a thoracentesis. And this is usually when we have a fluid collecting in the pleural space in the lower lobe, way down here. And depending on how much fluid, they might just go in and drain it, or they might put in a tube and for continual drainage if it's a lot. Because like I said, this fluid here is pushing up on the lung tissue. And it's going to cause the alveoli in that area to collapse because they can't expand because they're being pressed on. Now, to do this is consentable again. It's informed consent. We have to explain the procedure because up on the floors, they do it right at the bedside. They'll have the person sit upright, open, usually on the side of the bed, with their hands in front of them, lean over the bed table. Okay? And the doc will